had all told. Uh, they will tell you the rest about what they discussed. But I just wanted to say, complete my sentence. The three students who spoke were such powerful advocates. They were advocating for compassion, competence, and what they did not use the word ethics, but everything that they said was about unethical practice. They made it all possible. I only needed to be a bit of a facilitator, encouraging the group to talk, and then giving a 15 minutes presentation over the 1.5 hour session. So that worked as a beginning. But thank you for listening to me. Sripriya and Sreedevi, thank you. Back to you.
Thank you so much, all the group participants, for the active discussions that were happening. A lot of ideas we could hear, glimpses of ideas we could see while we were in all the rooms. Thank you so much for the wonderful discussion. Now we will, shall we start from group 5 then, the reverse order? Who was supposed to be summarizing from your side? I think it's Dr. Shivaranjani. Did she join or someone else was noting down the points? So who will be doing from your side?
Ma'am,
Yes, Dr. Swati. Yes.
yeah, Shivaranjani was not there.
Okay.
So we had done a little bit of homework, how to about the topic briefing. So along with that, with the first input, we would just like to present what how we would go about teaching the introduction to ethics for the students. Uh, as it was a large group session, we are planning. It was a large group session of 2 hours. So competency, what we wanted to address was what it means to be a doctor along with doctor-patient communication and foundation for ethics. Two competencies to cover. So initially, the set induction would be like asking the students themselves what were their experience, because they are the first year students who just coming in, asking their experience on what they had a prior experience of doctor-patient communication, their personal experience. Using that and taking the discussion forward. And the second thing would be to use any videos of the patient communication and ask them to reflect upon what are the points they could uh, uh, point out from that, what should be, which could be taken it for discussion. That was initial 10 to 15 minutes, followed by lectures with the PPT on what it means to be a professional qualities and the roles of a physician, and then what is identify and discuss the physician role in responsibility to the society and community. Then explain the 4 pillars of ethics with the examples. That is in the first session, first 1 hour session. For the finally winding up that session, we'll be summarizing what has been taken and allot few case scenarios next session for them to work on and discuss. So the second session, initially the first 10 minutes will be just recap what the previous session was, and later half it will be completely the wise discussion on the case what is being discussed. Finally, the last 10 minutes will be summarizing from the facilitator part.
Thank you so much, Dr. Swati, for taking up the presentation part, because your leader was not there in the group. Any inputs from other group members? Have you any of you have already taken this topic for the first year students, and how did it go, and what can be done more, or something which worked really well?
I think more or less what Madam said, we all have been using the same method, and I think when we give more interaction and leads to these students, they come up well with their opinions, and that may give us a lot of ideas for our next sessions. So that is one aspect which we would highlight.
Thank you, Dr. Puneet. Just for my own understanding, for the first year students, when we use case scenarios, will they be able to relate to the case scenarios because they might not have started seeing patients? So how will you manage that part?
I don't see any hindrance when it comes to terminologies, ma'am. And moreover, I think we have done enough of orientation just before we start. There are many medical terminologies.
Foundation course also they'll be having these ethic modules. So when they come to AdCom, they are usually they'll know what exactly it is.
Correct.
And just one opinion I have from my own experiences. Actually, what happens is in first year, the children are more uninhibited. They are less afraid of us. And talking about a topic like this is, I think, a place where they can be more open, free than talking about a topic that is more medical and more technical. So these are things that they will be able to more easily understand, or at least be more easily able to interact with. My personal experience is that. But as they grow up, as they go to second and third year, interactions will reduce a whole lot more. In first year, they're more open. They're very happy that they have gotten into MBBS. They're very, they're ready to be, understand and interact with anything and everything.
Maybe leveraging the enthusiasm of getting into the medical school will be the key thing in teaching, sir. Dr. Sairu, you were about to tell something.
I just wanted to tell that the case scenario, we need not give into big details of the case. Whatever a lay person understands, such sort of case scenarios will be understandable to them.
Exactly. Yeah.
Yeah, I think even Dr. Raina's session, she was mentioning about choosing the case scenarios wisely so that the student will be able to relate than going into too much of technical, ethical dilemmas. So that, I mean, they really don't know how to respond to those dilemmas probably.
So case scenarios for first year MBBS can be of the limit of lower order thinking skills, not the higher order thinking skills.
Yes, sir. Yes.
Rather than rather than a case scenario, it should be a story of a patient. Like anybody can understand, kind of. It's like not based on any clinical case presentation or anything. It should be like the story of the patient. Like
Ma'am, actually, in one of the AdCom module for first year MBBS is what does it mean to be a doctor? So what we used to do is we used to play a movie, that Patch Adams movie, to them. So, and then followed by a class. So it was very helpful for them, actually, that class. Patch Adams movie tells the ideal doctor to be.
Do they tend to become more funny like Patch
It is
Adams?
very entertaining because it is the module is 7 hours, 7 to 8
Yes.
hours. So
You
somehow
have enough time to, yeah.
7 to 8 hours. So 2 hours we used to put a movie. Then we used to ask their opinion or reflective writing about the movie. It was useful. They enjoyed also, and something they learn also.
So in the module that we have shared in the materials, I think we have certain case scenarios. If anyone wants to use the case scenarios, as you said, it is not too technical, but something which we come across on a regular basis, very basic, not specifically palliative care related scenarios. Also, it is very basic case scenarios. If anyone wants to use scenarios, we've given a sample format. Thank you so much, Group 5. Very well done. Moving to Group 4.
I am talking on behalf of Group 4, and am I supposed to present, or is it okay just to talk? I just want to know.
Your group had many presentations, so aren't you presenting?
Yeah, I will be presenting, but I think I am not allowed to present. Or I don't.
We'll just give us a moment.
Okay, so to begin with, ours is breaking,
Now
communicating
you
the
can
bad
present,
news.
Dr. Puneet,
Yeah.
if you want.
Communicating the bad news, and we have a very enthusiastic group, and I should thank Dr. Ramadevi, Dr. Sairu ma'am, which they could bring out two good presentations, and both are kind of I think it's not happening, but then I'll just go ahead. They had two methods. One is flipped classroom method, which we did just now for this FDP. The other module was kind of make group. You explain, give them the instructions, and then go ahead with the what is the activity for that day. So I'm just joining through laptop, ma'am. If you had to just approve something like my joining,
We
can
have
you?
given the right, or Dr. Ramadevi, yeah, if she has a presentation, she can present and you can discuss. If that is.
Do you want me to share? Puneet?
Yeah, I'll be doing it. I'll be just doing it through my laptop. I got it. I mean, my mobile was not. So I will pick up both because
Dr. Puneet, are you talking? We can see the screen, but we can't hear you.
am I audible?
Yes, now we can hear.
Okay, so
we would be trying to give them the skills and then explain how to build a rapport and demonstrate the certain skills of counseling, such as respecting the patient, being non-judgmental and empathetic. So the second thing, what madam is that we give two scenarios. One is the good communication, and the second one is the bad interaction. So, and then later on help us to know what is that good and bad, and then create a role plays about both the things. So the first patient scenario, we'll have two scenarios basically. In both the scenarios, we'll have good and bad. So that now the patient, it can be a discussion in the emergency room, or it can be a discussion in the ICU, or it can be in the ward. I think this scenarios will be different. So it will be good when we have this two scenarios. And so basically, we would provide them 30 minutes, and then through flip charts and whiteboard markers, we'll be able to do this discussion also. So in the second scenario, similarly, the same thing. One among the group, they'll have two groups. One will be doing the bad communication, one will be doing the good communication, and then we'll have a discussion. So then we have one more module Dr. Sairu ma'am had proposed. In this, we will have two sessions. First session will be kind of small group learning, where it will be the half of the batch, which he usually handles about 175 students, and then she did it for 2 hours, and then the SLO will be kind of trying to bring an orientation for the students to learn about the protocol, spikes protocol. And then the second session will be trying to divide them in groups and about 10 groups will be divided, and each group will be asked to make a role play about good and bad communication, and then try to discuss around the spikes protocol. So this is what is the competency for the module. The module will be something like these will be the topics in each of the this module, and the competency, what is the level of competency. Then we have the whether it can be an interaction or it can be a PPT or a lecture, and the time allotted. So very nicely done. And then what we can do in this particular group is like we show a video and then ask them what went wrong and what went right about both good and bad communication. And then once we put them in groups, we also ask them to write a script and then prepare for a role play and then enact, and again do a group discussion. And this can be done having mentors, no? So it can have multiple mentors, probably one mentor for each group. We can also train interns to do this mentorship. And also at the end of the session, we have a formative assessment, and end of posting, we may ask them to do a summative assessment. So a spokesperson from each group can summarize the whole group discussion, and then the whole class brings or takes up the relevant discussion points from each of the groups. So then the overall mentor, who has the session, who does the debriefing and ends the session. Thank you.
Thank you so much, Dr. Puneet, for summarizing your group's work. And wonderful presentation, Dr. Ramadevi and Dr. Sairu. I'm sure you might be doing this activity with students for so long, and everything is in place. I would like to hear from the other group participants. Anything to add or anything to ask, or any other comments?
So I think both the modules were great. So that's where I thought I'll present both. And then I want to ask if any of the other participants in the group can bring in their inputs of how they did. Like Sairu ma'am had already done this. So do we have any other module like where teachers enact and you ask the students, was that done anytime? Or you want to bring in a real patient, bring them to the wards, and then discuss out of the classroom?
Hello.
Yes, Dr. Priya.
Yeah, in our hospital, actually, where we were teaching the students in our college, we have some of our doctors are very into in doing this actually. So one becomes a patient, one becomes a relative. So we do it as a sort of a small skit before we start off with the actual teaching. So it works very well. So they are also very happy seeing that, their teachers performing this. We don't take them to the ward, especially first year and second year, but we do this as a form of a skit.
Any other models?
Able to take them to the ward. What I could do is we had one intern at the ward, and then we could use this small jugaad, like have this camera on and then make the patient talk, and the same thing is projected on the classroom through the Zoom and things like that. It did work well, so they have that real patient experience coming out from the ward. So
that is a very good idea, Dr. Puneet. Like yesterday, I think day before yesterday, we were discussing how can we take all these 150 students for observing something in the ward. So this might be one way to do that. I think that is a wonderful idea. You can ask permission from the patient whether we can. It's kind of broadcasting to the whole class, and it's not like a hypothetical situation or a movie or anything. It's the actual experience that they are seeing live. That makes a lot of difference. Thank you so much for that's a very good idea. We'll also try to do that.
I think we want to have this because I know day in and day out there's a lot of visits, home visits this Palam India is doing, and then probably we can really see that real life scenario where you're reaching out and then what's happening. I hope it happens because bandwidth and other things may matter when we do it like in Zoom and having a lot of people. So maybe we can try next.
Yeah, that's what exactly I was thinking. Most of our training programs, when we do virtually, you miss the real hands-on experience unless you come here. So although this cannot be matched with that, maybe something we can try from a real life experience from the field broadcasting to the if the patient is okay with that. Sir,
Yeah.
I hope you heard that idea, sir. Maybe we can try it.
Great.
Thank you, sir. Thank you.
Thank you so much, Group 4. Now we can move on to Group 3.
So our topic is collusion. So the SLO for the class will be at the end of the lecture. The student should be able to describe collusion and the factors responsible for it, and also should be able to explain the steps in managing collusion. So moving on to the lecture class proper, like the theory class. So initially we will be having a set induction in the form of a case scenario. The case scenario will be a poll, okay? Like whether they will be going, the students will be going for hiding the truth or not hiding the truth. So that will be the initial poll thing. Then this will be followed by lecture classes, which will be dealing about definition of collusion, factors causing collusion. So that will also include dealing about total pain and need for breaking collusion, then the harms of collusion, and finally steps in managing collusion. And in that steps in managing collusion, we will also be dealing about anger and denial, the consequences of like preventing collusion. So then this will be followed by the case scenario. So the case scenario will be again be projected. So the case scenario will again be shown. And then this will be followed by a role play. So the role play will be telling how to manage collusion. Regarding this role play, it is given in the module like of collusion as shared in this FDP thing. And then assessment will be in the form of case scenario. So the steps in managing collusion will be enacted in the form of role play. So these all will be coming in the 1 hour session of collusion.
Thank you, Dr. Karthika. Anyone else from the same group or another group would like to add anything?
So we can also include pre-test and post-test.
Yes, very true. It's very important, especially these topics will be little new or maybe having different opinions in the beginning. So pre-test and post-test to evaluate is a very good idea to incorporate.
We'll also be dealing about the spikes approach in dealing with collusion.
How easy, like in your experience, all of you might be doing role plays and discussions in your institution. How easy it is to get students to do role plays and plan the scenario and make sure that others are not teasing them when they do the role play.
Pertaining to this topic, like pertaining to the topic of collusion, it is given in the module, but real life scenarios, I'm not sure.
Sairo ma'am, you were telling something.
I think only thing we have to be make sure that the role play, we have to give proper instructions. Make sure that the role play doesn't focus on, how to make it very hilarious or something like that, or make it so enjoyable. You should tell what is your objective. And if you make your ground rules clear, I think the students enjoy role play because basically they like those sort of creative methods. That's what I have found.
Yes, ma'am. So that's exactly what I wanted to convey. When you have a scenario, you can't just call to students and tell them to do. It will be very disorganized, and then we may not be able to convey what we want to convey. So make it a structure, give them the roles, make sure that they understand what they are expected to do. Give them, if they are stuck, give them just a break there, and then start having some kind of discussion and proceed from there. Sometimes we get stuck when we do role play, especially when you know that you are doing a role play. You don't know how to go ahead. So those ground rules should be conveyed to the group, and the people doing role play should be very clear about what this scenario is, what are they supposed to do there. Then definitely it will go really well. So from our side, we need some background work on how we are going to do, how much time we are going to give. When they are uncomfortable or when they are stuck, we have to give the break there. So all these things have to be planned a little bit ahead of the session.
One more point I want to make. I give a chance for the peers to make a comment. So they are also very serious. So when the peer, sometimes it is a time to correct them also, because whatever is said and done, sometimes people become judgmental, ariyade, because it's part of our usual thing. We can always point out that to them, sometimes.
Yes. True.
So it is actually, it need not be a very, what do you call strict in the strict sense. It should not be a very nervous
yes.
exercise.
Yeah.
They can enjoy it. They can also learn how to correct in case they go wrong in something they say. So the peers, I have found that the peers will point out exactly what we wanted to say.
So maybe after the role play, ask the students themselves, like, what do you think about this, or something from their side, what do they want to comment on whatever has happened. So they, as madam said, usually they themselves will come up with whatever we want to convey in a PowerPoint. And as sir was mentioning in that fifth group, that then you need only 10 minutes lecture in the end to summarize what they have told you from the role play. Okay, this is what it is, points only you need to summarize in the end.
And you can take a feedback from the students. Then you something has gone wrong in your your session, and you can improve it for the next batch.
Yes.
Good feedback. They may not otherwise tell the bad things openly.
Yes. So, Dr. Parul, Dr. Sunil, and Dr. Baburaj, anything from your side so far from group 4, 5, and 3?
No, Sreedevi.
No, ma'am, it's going good.
Can we move on to group 2 then? Yeah. Group 2, Dr. Kannan. Dr. Kannan, you're muted.
Yeah. Am I audible now?
Yes, you are.
Yeah, good evening all. We plan to give more importance for interactive session. So our topic will be on active listening, and the competency will be shows how the participants are interns. Number will be 75. So initially we planned for a continuous second part will be the second one. Our second half will be solely role play. That's what I wanna explain first. So that's a brief about our plan. So first we will give the pre-test in the form of MCQs, That is, we'll send a Google form a day prior. Then we'll start with the session with a set of set inductions with some picture depicting good or bad communications, and we'll be having some sort of interactive sessions. It will be around 10 to 15 minutes. Then we'll go for an interactive lecture class with some videos covering all the points of communications and barriers of active listenings and all these things. At the end of the sessions, we'll be go for a assessment with post test, and then second part will be a role play. We'll make a small group and we'll ask them to role play, and then we'll go for a formative assessment in the form of asking, and then for reflection part, we'll ask them to give some sort of feedback in 100 words. This is what we planned. Anything else to add?
In between we lost you. I think I heard most of the parts, but in between we were losing you.
Should I repeat?
No. Anything from your group members? I think your network was breaking in between. Any of your group members would like to add to what Dr. Kannan said? I heard about the overall part, but it was breaking in between all the time. I don't know whether it was my network issue from here. Others were able to hear.
No, ma'am.
Should I repeat? Hello.
Can you summarize what you were telling? Just summary. Maybe you can switch off your video.
Yeah.
Your network was not really good.
Yeah, sure. So am I audible now?
Yes, you are.
Yeah, actually, we planned for a 2-hour session. First half will be a interactive lecture, and second 1 hour will be totally of for role play. Okay, so initially we'll be giving that Google form a day prior. We'll collect it in the form of pre-test. We'll start with set induction, depicting some pictures or videos, and we'll discuss about what are the good and bad communications or how to deal with those things. And we'll go for interactive lecture class with some videos, and at the end of that lecture we'll give some sort of PPTs listing that what are the barriers and how to deal with those barriers, and then we'll go for a post test, okay, in the form of MCQs. This is about first session. The second session will be a role play. We'll make them into a small group, and we'll ask them to pick up a leader, and we'll ask them to do that role play. At the end of the role play, we'll assess by observing how they are doing that role play. And the second part, reflection part, we'll ask them to write down the feedback in the form of 100 to 150 words, and we'll ask them to submit that feedback. Am I audible?
Yes, we heard you clearly now. Thank you so much, Dr. Kannan, for repeating the whole thing for us.
Thank you.
Any other comments from the other group participants or the mentors, especially in teaching active listening? Any other method that you have tried or you can suggest?
Hi, can I speak?
Dr. Anupama, please.
Yes. So we conducted this communications module under EdCom for most of our batches here. I'll just tell what I did here. It is just one of the methods. There are a lot of methods I think everybody is doing. So the first thing for communications module, as far as active listening especially is concerned, how I started the session is we start with a game that is 20 questions. I don't know how many of you are aware of the game. So 20 questions is a game in which it's all about closed-ended questions. And one of the components of active listening is you start with an open-ended question and then you actively listen. Your body language should match with what the person is saying. And then you keep paraphrasing if there is something that needs to be rectified during the conversation or after the person has stopped talking. And then at the end of it, you summarize and whether you've reached a conclusion or not. So as far as I remember, these are the components of active listening. So I demonstrate the components of active listening using this game. So we start with the game. The game is, let's say I choose the student only and then I give them a word. Let's say I give them a word that is a car. And now the team has, all the students are involved in the game and they have 20 questions and the answer will be only yes or no by the person who knows the word. And then they can keep asking questions in order to get to an answer before the 20 questions are up. So usually they start off with something like, is it a living thing? So if the answer is yes, it's a living thing. If the answer is no, it's a non-living thing. You can't ask and or questions. So all the rules are told. We have one kind of a rally, a fake thing, and then we go into actually utilizing it. And by the end of 2 or 3 rounds, now that they're aware of the game and they know the rules and all of that, and they're also understanding like how the game is going, like how it is important for them to keep summarizing what all already has been asked so that they don't waste questions. They're focusing on listening to their own fellow students and what all questions have already been gone, so that those 20 questions are precious. This has happened a lot of times that student in a hurry to ask their own question, they don't listen whether it has already been asked. Or let's say someone has already removed, is it an electronic gadget? And then someone ends up asking, is it a phone? Or someone asks already the question, is it in this room? And when the answer is already no, then they again ask something like, is it an ID card? When you have eliminated a whole set of room, then everything in the room, including yourself, your spectacles, whatever you're wearing, whatever gadgets you're carrying, anything that can be seen has already been eliminated. So it's like they're actively listening to the questions, they're focusing on what has already been done, and then they're summarizing to themselves. So as in the number of plays increases, they keep on understanding that they have to listen to the others' questions. They have to see what has already been done. They have to also manipulate the data in their head so they don't waste the other question. And then they summarize it to themselves. Like, this has already been asked, this has already been, so it's not this, it's not that. You can see it's actually happening right in front of you without actually giving them much to do. They feel like they're playing just a game, but at the end of it, I show them the process that they've done. I summarize it for them. So you've done this, you've done that, you've done that. And this was not just a game. This was also how active listening usually happens. And whenever there were doubts, you kind of solved it for yourselves by asking them the questions like, why did you ask the question? What was your intention? And things like that. And then the next thing I do is I ask them to start sharing the recent class experience or whatever. And then I myself demonstrate again all the components of active listening. I do actually listen to what they're saying, and then I paraphrase and then summarize. So throughout the session, 2 or 3 times it's done when it's being introduced, and then we go into the case scenarios. And I've seen time and again all my students, because this is how I start my class, they expect a game from me every time I start a class.
Thank you, Dr. Anupama, for sharing. So you will be able to connect this activity with the patient scenario also, right? In the end, you will be summarizing, connect what they have experienced to the scenario with patient.
Yes, ma'am. Yes. I will be connecting it. So this is usually essentially done active listening, I think, as a part of first year module. So when they come to me in clinics, because psychiatry, I am surprised that psychiatry is a posting in second year itself, but they do come to me for 15 days. And every time they come to me, I keep reiterating whatever games we have played to connect it to real life scenarios.
Great.
Even Kalamazoo checklist or whatever it is, I remind them the game and they remember the game. And then I connect it to the components of what I taught to them through the game.
Yeah, because that is important, right? Once you connect it, when they come to the clinical exposure or sometime towards the end of the session, otherwise the game will be a game. They don't, they might have enjoyed, but so it's very important to show them how this is applicable to the situation. Thank you so much, Dr. Anupama, for sharing that. Maybe others can also try using the game. Now we'll move on to group 1, the last group.
Very good evening, everyone. Today's topic is communication skill empathy, and the time for the class is around 1 hour. And the SLO for this class will be in the end of the session. The students were able to explain the principles of communication and discuss the good communication and demonstrate ability to communicate to the patients and their families in a respectable, non-judgmental and empathetic manner. So moving on to the class, we'll send a video to the students in the previous day, and we'll tell them to watch the video and come back. In the class, as a set induction, we'll ask the students to comment on the video. Like we'll ask them, say what you see. So it will take around 5 minutes. Then moving on to the lecture, didactic lecture, we'll start with the introduction about the basic communication skill and effective communication, on how well the good communication will help them in the patient care, and about the components of the good communication. And later on, we'll move on to the main topic of empathy, definition of empathy, and how it is different from sympathy and compassion. And then the empathy's role in healthcare, and benefits of empathy in patient's care. And then we'll give some empathetic response examples. So this will cover up 15 minutes. And later on, we'll ask the patients to share their own experience, how they felt about the empathetic situation they felt in their life. And then it will take around for the 10 minutes, like interactive section. Then we'll do a role play. It will cover up for 30 minutes. In this role play, we'll divide the whole class into 4 groups. We'll give time for them for 10 minutes to come up with a scenario. So each group will perform for 3 or 4 minutes, and will give us a discussion for 1 minute. So it will cover up 30 minutes. The total class will be 60 minutes. In the end of the session, as a post-test evaluation, we can do assignment for the homework purpose. They can visit any nearby pediatric care center and see a real patient scenario, and then they can come up with a write-up later on. This will be our total class plan.
Thank you so much, Dr. Amarnath. I would like to hear any other comments from other participants. I think empathy is one topic which is a little difficult to teach, because it's something to deal with the emotions and the feel than the theoretical part. So it will be wonderful to hear from other participants. Any experience in teaching empathy, and how did you do it? Any other participants?
I have of late felt that now empathy, the word empathy is common parlance in the medical student's tongue. Whatever you say, they say empathy. Sometimes I feel whether they really know the meaning of that. Because from first year, we are now telling about empathy, putting yourself in another person's shoe. So that word comes automatically now. And sometimes I wonder whether they really know how to put it into practice. This is just a perspective.
I've tried when I was in Manipal to teach the topic empathy. It was very difficult when you can't make a didactic. Yes, you can. You need some interactive session also, but it is very difficult to make them feel and understand and why it is important and etc. I think it will be more challenging with the medical students also. Thank you so much for your comment.
Me again?
Yes, ma'am, please.
Okay, so it is a little extreme, but I do find that one thing has helped me in teaching students or approaching when they say empathy. Like Sairu ma'am has said, it is very true. Whenever we ask what is a good communication skill, the first thing they come up with is empathy. And when I ask them what is the difference between sympathy and empathy, they immediately say you are in the patient's shoes. So then I give them an example to say that, so you're telling me that if you are literally in the patient's shoes, it means in order to understand the pain of a person who has broken their bone, you should also break your bone. And that immediately wakes everyone up. They're like, they're shocked. What is she saying? Why is she asking us to break our bone in order to understand a person who has broken their bone? So, and from there, I just keep waiting. I'm like, I keep asking that question. So, you're telling me you have to break your bone to understand a person who has fractured their bone. And then they come up with answers and they come up with answers and they come up with beautiful answers, ma'am. One of the answers that came up from the students itself was, one of the students said, I would be not comfortable if they start removing my clothes in the ER when I come in the stretcher just because they want to access my fracture site. I would like to be taken inside a room when they're doing that. So when I take it step by step, when I say what happens when a fracture is happening, how you're bombarded with questions when a person comes in, how is it that 10 people are around you, one is trying to access your fracture site, one is trying to secure a line, nobody's bothered about your pain, nobody's bothered about, they're just looking at you as a body with a fracture instead of a person. So when I ask these questions and I take them step by step of how a person who has been in a fracture, and then I add a component like it's an alcoholic who's been in a accident, and the accident happened because he was drunk driving. And then empathy is hard to arise in those situations, but then how would you deal with it? Would you not treat him, or would you judge him for getting into an accident, or would you still approach him? So when I take it like a story and I present it to them, they actually do come up with answers. It just takes some time, I realized. And there is also a game. It's definitely not possible in 1 hour, but the game that I do apply when I teach it as a module, as a workshop for empathy is we divide the people into groups, and then I ask them to write something that has been stressful event for them, the most recent stressful event, put it in a chit, and then mix up all those chits and then randomly allocate the chit to some other person. Now this person is dealing with another person's problem as their own, and then they would give an answer. So that is literally in their shoes. So the person is looking at the problem from another person's perspective, and this person is also dealing something that they would not actually dealt with. And when I did this with students, they did come up with some silly questions like, today I missed breakfast. And one of the students who got the chit got angry and got irritated, like, what is this question, ma'am? How will I be empathetic if he missed breakfast? And then there was another student who got up and said, like, I have a Parle-G packet, whoever it is can just take this because you missed breakfast. And then they just keep surprising us with the answers and with the empathy they show. Students, I realize students are more capable than us in learning as far as our teaching goes. Sorry for taking up time. Thank you.
No problem, Dr. Anupama. It will be wonderful if you can write down these activities and share with us so that maybe more people can make use of these kind of teaching activities, especially for topics like this. Thank you so much for sharing your experience. It is good learning for us also.
Shall I add one more thing?
Yes, ma'am.
Maybe empathy becomes real for medical students, or rather it will translate from the theory or definition to real if they see it in their setting. Okay, if they see the real empathy in your real life situation, I think they will understand it better. But unfortunately, in many of the instances, they are not able to see the real empathy in their day-to-day situations, and other other things supersede. So it is not actually the fault of the students. Actually, maybe the hidden curriculum. There is a hidden curriculum everywhere. So that is what it makes it maybe restricted to a theory or a definition.
Thank you so much, ma'am. Maybe one more factor might be they might have listened to all this in the initial, the first year, or maybe there is something entirely different that they will be seeing in the wards as modeling. So they might not be able to relate. For example, if you are Dr. Anupama did this activity for the first year students, and then they go to another ward where they will be seeing entirely different way the situation is dealt with, where the fracture is dealt exactly the way that you did not want to. So probably they cannot relate or apply whatever they have gained. So I think that modeling is very, very powerful. How what they see as models is also very important. Thank you so much, all the participants. A quick round from the experts in the group. Dr. Parul, Dr. Sunil, and Dr. Baburaj, before we wind up today's session.
So I think all of the topics today would actually we need to show them how it has to be done. And many of you have also talked about that. It is very, as you told, dignity or collusion, communicating badly. So all those are, we can say some theory, but if you do it in the practical setting, then only we would know how difficult it is and what are the difficulties we have to face. And even in role plays, some may become very emotional and things like that. So, for understanding these subjects better, I think role plays are a good way to go.
Yeah, ma'am. The Sunil sir said, especially when we become interns, because of the time constraint, whatever you can say in the emergency department or in the wards, the communication part which all they have learned during their curriculum, they won't. Many the times it's like for them they feel it's very difficult for them to apply during emergency situations or in the ED. Before that, what I believe is constant interactions with the patients and constant role play will make them prepared for that time period, for that time when they're actually dealing with the patients on one-on-one basis. So yeah, I think role play will be a good idea, and not at once, but constantly in every year, especially during internship also.
Thank you, Dr. Parul. Yeah, role plays, I think only after conducting a few, we'll also be getting used to how to prepare for role plays according to the year in which they are, etc. Thank you so much, Dr. Parul. So, Dr. Baburaj, any closing comments from your side?
Say something of the technical. Am I audible?
No, sir, your voice is not clear.
Am I audible now?
No, sir.
Feeble, very feeble sound.
Sir, can you just try, if you are using a headset, can you just try removing it once and then pinning it again?
Or can you try without the microphone?
There's some problem with my.
I think there is some technical issue with Dr. Baburaj's earphone. Dr. Sunil, can we wind up today's session?
Yes, please.
Thank you so much, everyone, for the wonderful discussion and sharing your learning experience. And Dr. Anupama, please write a note to us so that we can add it to the session on empathies for the learning materials that we share with everyone.
Definitely.
If you have some time. Thank you so much.
Thank you, everyone. Just reminding that tomorrow is our last day of this wonderful program. This is Sreedevi along with all the valued mentors and Dr. Sreedevi Warrrier, signing off from the Valued Media's desk. See you in the next session. Till then, take care. Bye-bye.